Welcome back. I am pleased to introduce our first spotlight on innovation, how Medicare Advantage improves chronic disease management. This will be a fireside chat between Dr. Smit Patel with Digital Medicine Society and Geoff Mattous with Wellinks.
Hi everybody, welcome back from refreshments. As you can see, there is a 3D figure here, and you'll see there would be a 2D figure right next to me on the screens. Really excited to have you. Thank you to BMA for having us for this fireside chat. Just like healthcare, my colleague Geoff Mattous, who I was supposed to interview, and there we go, you see Geoff there, who wasn't able to join in today. Flight challenges, very similar to healthcare, where our patients cannot come into clinics, and we adjust. If one thing that post-pandemic has taught us is how do we innovate and how do we think and be more flexible around in our lives and in patients' lives. So without further ado, let's get started in a few minutes once Geoff is able to join very shortly. Awesome. Geoff, could you hear us? Give us a thumbs up.
Yeah, I can hear you great.
Oh, beautiful. Isn't it when all tech in the virtual world works? Virtual plus, in-person hybrid. So without further ado, let's get started. How we will use our time of the guest speaker today. We'll kick off with introductions real quick and then dive into some of the real meaty discussion on some of the work that Wellinks is doing as a part of support with Medicare. So I'm Smit Patel. I'm the program lead at Digital Medicine Society, or DIME. We are a global nonprofit that supports safe, effective, ethical, and equitable use of digital technologies to optimize human health. How we do it is we bring institutions, organizations together in a pre-competitive space from investors, payers, regulators, health systems, digital health innovators, tech organizations, life science industry, cybersecurity professionals across the companion for health and technology together to build standardized frameworks, best practices, and research for what is impending in the field. So really excited to be here. And without further ado, I would love to have introduction from Geoff. Geoff, please kick us off.
Thanks, Smit. It's so good to see you. Apologies, I'm not able to be there in person today. I do appreciate that I have a water on stage, so feel free to have two. It's a pleasure again. My name is Geoff Mattous. I'm President and Chief Commercial Officer of Wellinks. Wellinks we'll hear a little bit about, I'm sure, later, but we are the first ever integrated disease management solution for COPD specifically. We use health coaching, clinical care, virtual pulmonary rehab, and technology to connect with our members wherever they are and bring evidence-based medicine to their home to help them stay out of the hospital, live healthy at home, and ultimately to live fully and breathe freely. So thanks for being here. Medicare Advantage is an important topic to our business and to the patients that we serve, and look forward to exploring that further.
Fantastic. Thank you for the introduction, and again, really appreciate BMA for having us today. So we're at the BMA Summit. Let's kick off with Geoff. Tell us about why is it important for Wellinks and how they have been using ME as this growth incubation for Wellinks. Please share with the audience.
Yeah, so maybe I should back up maybe just a little bit and set the stage for what COPD is and why it's a problem and why specifically it's a problem in the population served by Medicare Advantage plans. So COPD is chronic obstructive pulmonary disease. It's an obstructive disease of the lungs. There are over 25 million people living with COPD in the US alone. It's the third leading cause of death by disease and the fifth most costly chronic condition. like you heard about Medicare Advantage members before, our members, or those who live with COPD broadly, tend to be a little older, tend to have more complex care needs, and are often located in rural environments where access to brick and mortar care can be a challenge. So when you think about that overlap between the populations that we are trying to serve and those that Medicare Advantage is serving today, is about to serve over 50% of eligible Medicare beneficiaries soon, it makes sense for us to focus on Medicare Advantage as a place to access, reach, serve, and care for those members together. We talked about the difference between go-to-market motions for some different, for virtual care or virtual first care companies like ours. And the reason why for those who are focused on diseases typically affecting older adults, Medicare Advantage makes sense is because there's just not a path otherwise. So literally companies like ours cannot exist without programs like Medicare Advantage providing an innovation ground for us to work outside of the traditional frameworks of straight Medicare and fee-for-service environments, to test different care and payment models, and to really blossom innovations that ultimately can more broadly reach populations in the future.
Fantastic. You know, there are multiple things I want to scrape down from this, as you mentioned, Geoff, but let's start with, you know, as a clinician, I've seen in my side of the shop when treating patients, COPD is one of the major chronic conditions besides cardiovascular diseases, diabetes. But what we have seen is innovation solutions lagging in the space of COPD as we think about more in the digitized world. Before we dive into nuts and bolts on how MA has helped you build Wellinks, could you share what problem is Wellinks solving with COPD and why this is the right time we should be thinking about solving using digital solutions, especially for COPD?
Yeah, great. So I think the first part of the statement there, I think is important to note that there are incredible innovations across many different disease states, across integrating different solutions. There's a lot going on there. And we see consistently the go-to-market motion for companies that are looking to innovate care often involves some mix of direct-to-consumer for those who can pay out of pocket. That creates the flywheel. Then it moves to the employer, where the chief human resources officer or someone else serving the employed population is making benefits decisions that are good for their employee base. Because we just talked about the dynamics of people living with COPD, we know that there's not access to those patients in those populations. So solutions aren't built that follow that same path. The time is coming, though, and you're seeing more senior and older adult focused care solutions and innovations coming to the market. A lot of them are coming through Medicare Advantage or other payment innovation models. But the problem that we're trying to solve specifically is for those older adults living with COPD, it's breaking down access barriers. So we know that things like pulmonary rehabilitation can be incredibly effective. In fact, there was a recent JAMA paper that was published that showed that it's cost effective to the tune of $5,700 per patient and significantly improves quality adjusted life years. But in Medicare fee-for-service, only 4% of Medicare beneficiaries go on to receive pulmonary rehab, Medicare Part B. Why is that? The payment models and the incentives aren't the most attractive things for hospital systems and others to invest in building centers. There's challenge with just getting to a facility. Someone who is often isolated to the home, doesn't have access to transportation, difficult to get in a car and drive 40 miles each way to the nearest facility. There's a limited number. So there's 18,000 people in the United States diagnosed with COPD for every one outpatient pulmonary rehab center. And the model is challenging because you have to keep going back every 16 weeks. Now, we know that virtual pulmonary rehabilitation or programs that can be delivered in the home have been proven non-inferior to center-based rehab, but they haven't really come to the market yet. So we saw an opportunity to really close that gap to help our members, and we knew we needed to do more. So we need to help with behavioral matters, habit forming. We needed to help with access to medication and affordable drugs. Needed to help with coping with living with supplemental oxygen, trying to take the whole individual living with COPD and not just focus on COPD, use that as a lead condition for the conversation, but really address the health of the whole individual. That's the problem we're trying to solve. We're really just getting started and believe in a really bright future for people living with this condition and others.
I really like that. And that reminds me of one of the points, Geoff, you and I have worked together, and Dime and Wellinks have worked together on a new impact initiative. So for individuals who may not know, impact is virtual first medical practice collaborative that is being co-hosted with American Telemedicine Association and Digital Medicine Society, that's bringing together, convening multiple stakeholders and various payer organization innovators, digital health solution providers together to define what good looks like in the virtual care world. So not like a patchwork of things that, oh, providers picking up a Zoom call and calling during pandemic, but how do we define a virtual first care that is with the right stack models, that has the right payment infrastructure, that identifies what good looks like in the next post-pandemic world. This work started 2 years ago, where we were building care pathways, essentially when a patient is, say, oncology patient is going through radiology clinic and going through virtual consultation with the patient, to doing lab reports, to imaging, to getting the medication from pharmacy. If we think about traditional world and think about a virtual world combined together, how does these pathways map out and what it looks like? It's complex. And we are now living in this complex world, just like today as we see, we make things work. And with Impact, Wellinks, with Geoff's leadership, has been a part of this initiative. So Geoff, tell us a little bit around, we have worked together on some of these work streams and built solutions. You have tested this and implemented this model at Wellinks and even beyond. Could you share some insights around that and your leadership with it?
Yeah, sure. I mean, it's been one of my greatest pleasures to be involved with the work at Impact and with Digital Medicine Society. And I always say it was one of the best decisions that we made about 2 years ago when we joined, because we started to get involved in a conversation that is pre-competitive, safe space, roll up the sleeves and do some work together and really help each other solve some problems. I think that's the direction that's the position that all of the companies come to it from. There's incredible sponsor organizations and strategics and Dime committing an awful lot of brain capital into this work. So like, let's see if I get them right, but I believe the first work stream we started on was just defining the field. So we had to wrestle. It's like, well, what is virtual first care? And what does that mean? And does it mean it's virtual only? Or does it mean that automatically the first thing you do is engage in a virtual environment? Or does it mean that virtual as a first option, but the traditional healthcare ecosystem is there to support? And I think we addressed that one really well. There has certainly been some like additional confusion coming in as we start hearing about virtual first primary care health plans and all of this other stuff. But V1C is here to stay, and you see it across a lot of companies. Then we started to focus on, I think the second work stream was where we went and said, well, how do you take this to the market? And to the Medicare Advantage plans in the audience, a lot of this was, how do we understand how to work with you and do it in a way that you're used to doing? Because we don't want to show up and be put in the, call it the land of the misfit toys of just technology solutions and software, where, geez, we haven't bought a lot of software before, we haven't used it in care delivery, and when we do buy it, we measure its effectiveness in a different way. And we were coming to the table and saying, well, we're really providers, but instead of showing up in a brick and mortar setting in your network, we're showing up in this kind of hybrid environment. And going through the detail of how do we contract, what does success look like, how do we set achievable KPIs that matter to you? And that was, I think, the first thing that we really tested out as a company, is we literally took the playbook that we developed with Impact and Digital Medicine Society, and at that point, probably 30 other founding members, and started going out and saying, can we contract as a credentialed provider in your network instead of being a solution vendor, right? Can we bill the codes that are available to brick and mortar providers instead of having to come up with a service price? And how do we structure appropriate risk and put some skin in the game so that we're part of the same solutions that you're looking to solve problems? That has been, I think, fairly a little bit of a trial, right? So some plans and payers are really getting it. They have a system for this, they're comfortable with it. Others are still wanting to engage as vended solutions and sign business associate agreements and all that. I think there's room for both. I believe this market will evolve to saying, site of service aside, care is care, and we're going to hold care to the same standards across different environments. The final and most recent work stream we worked on was the transitions of care. And I remember going through this. So we chose COPD as as the transition of care vignette that we decided to do with Dime. And we're mapping this journey of a patient from ED visit through hospital admission, through discharge, transition to the home, and everything downstream of that. And I remember looking, I think it was Whimsical, one of these boards that you can make a lot of blocks on and collaborate on. My colleague Ellen is amazing at these things, but for me, they're just like, it looks really, really crazy and daunting. And I remember seeing all of these different lines and boxes, and each of those was a handoff point where you could potentially lose a patient or have friction in the journey. And I think it was important for us at that point to say, this is real, this is how messy this is going to be. And we need to figure out how to drive transition from one site of service to the next without losing information, and making sure we're bringing people along, whether it's the care team in the brick and mortar setting or care team going to the patient's home. And we tested that out. We brought it to a large healthcare system only probably 60 days after we built out the framework with the team. And we launched a study that we recently announced called Power with Hartford Healthcare up here in the Northeast. And we dove right into that environment, taking frail, elderly patients with major complex chronic conditions and helping them get out of the hospital to the home. We've seen many of those patients cross that 90-day window without a readmission. Some who had just previously had as many as 4 readmissions in the prior year and are dealing with things like life continuing to go on that you have to deal with when you're trying to deal with your health, or exacerbations coming on and not knowing what the first strategy is, but we can help with that, or having a medication adherence issue and reconciliation issue and having 2 different, you see this as a pharmacist, 2 different medications at the home at the same time and not knowing which one is your maintenance medication and which one is your rescue inhaler. And the work that we did with Impact really helped us to accelerate to Impact and find success there. The program has been going really well, and it's a pleasure working with your group all the time, Smit.
Thank you. Really appreciate, Geoff. And I think this is something that we are still building. It is not done yet, and there's a lot more work that needs to be done in terms of, as we think about care transition moving into the post-pandemic world, how do we ensure we are delivering right quality care in the traditional brick and mortars versus the virtual first? What are the right value measures, and what is the right impact that we should be measuring is something we still have to identify and build frameworks that most effectively, at the end of the day, we're not building another point solutions in the more fragmented healthcare system, but essentially, how can we synchronize that over the period of time? Geoff, one of the things we also saw is the fact that there were a lot of innovation that was building for the employer-based employers market, essentially. So for people like me, people like you, but then no one was thinking about people like my parents and my grandparents and people who actually need the care during pandemic and now even going beyond pandemic. What is Wellinks doing differently, and what can we do about that?
Yeah, I think, we did touch on maybe why some of that innovation wasn't touching the senior segments, and a lot of that has to do with the employer segment being a large buyer or purchaser of healthcare, and that makes a lot of sense. But I do think there are a lot of folks out there who are looking at an aging population, 10,000 people a day turning 65, looking at our parents and seeing them start to have more complex care needs and wanting to build. So behind Wellinks, there's hundreds of others of great companies building in this space. And what do they have? The good ones, the ones that make it, what do they have to do differently? They can't just copy and paste what works in an employer or commercial population and put it into Medicare Advantage or an accountable care organization or any environment to treat seniors. You gotta start with the patient, or we call them the member. You have to build the journey around them. You have to think about their needs. You have to definitely stress test the question of, is technical literacy an issue or not? We found that you can bring people along and help them use technology, and even if it's not native to their daily life and their current lived experience, it can become part of it. So don't kind of throw the baby out with the bathwater and say that's not going to work, but be thoughtful about it, right? So there are nuances in designing.
And the Zoom will resume very shortly, so please hang on that. On that note, when Geoff was mentioning about tech literacy, one of the very interesting facts, and I promise this is more interesting than the Zoom going out, that I recently read is www, or World Wide Web, and emails, the age of the emails, were very ubiquitous in 1997. At that time, I remember my parents using and being fascinated about www and the internet and emails. In 1997, the 44-year-old individuals, men, women, other individuals and populations, today are 65 years old and on Medicare. So we need to stop belaboring the fact that senior individuals cannot use or won't use digital services, but rather change the narrative and flip the script around, thinking on how can we build solutions that works for them. And I'm sure I can see some chuckles, like, ask my parents, they use Facebook and WhatsApp so much better than even myself, being millennial. So if we build and design solutions with the right tech literacy standards, with the right DE&I standards to make sure these solutions actually are going to be used by individuals, I think that's how we will change it. And I think we will jump into the conversations very shortly when Geoff comes online. But within then, any questions from the team that anyone has? Yes, please. We have a question and we are going to change the narrative here.
Okay, thank you. Kathleen Sheehan again with the ALS Association. This was tremendously helpful in terms of the services that are being offered. I guess one of the things to think about as Congress considers what it's going to do with telehealth is whether or not they will consider covering some of these critical things. For ALS, I know that we had to fight to get telehealth provide coverage for the diagnosis of speech-generating devices. So we had many people who couldn't speak, and because they couldn't get in to see the therapist, were waiting for that authorization, and then also with regard to swallowing. So I think there are some complex and expensive situations where telehealth and this kind of coaching can be very important. But I'm not 100% sure whether Congress realizes that and will be willing to provide coverage. Clearly, we know that with the pandemic ending, that there is going to be some concern about waste, fraud, and abuse, and mechanisms put in place to control that. So I just wanted to put that question on the table, and I don't think there's an answer, but I think it's important that we work together to help Congress realize the importance of this.
Kathy, first of all, thank you for bringing that up. And I think it's one of the most important questions around why for impact. And I'll give you an example of impact because we have heard this again and again. What would we do once this public health emergency goes out and we may not see the coverages of virtual care solutions? And I think that's why American Telemedicine Association, who is our co-host of Impact, is taking the lead on the policy front of the side in terms of if we think about state parity laws that are restricting some of these services across the board. So individuals who may not know, a clinician in one state cannot deliver virtually a clinical service or a teleconsultation on a different state. These are similar questions and conversations that we need to be pushing from the policy front. And I know ATA has started the policy divisions trying to expand, one, curb down the restrictions for the parity laws, and then two, think around how can we expand the virtual care access. And I see that Geoff is back. What a wonderful way to turn back the conversation. Geoff, we were just discussing about our a stat that we all were mesmerized with when we think about 44-year-olds who have used www and grew up with internet over the last few years and today are 65 and potentially on Medicare. Could you share a little bit around how can we design and why tech literacy is important as a part of designing solutions or innovations for our senior citizens?
Yeah, of course. And I apologize, I don't know where we lost each other before, but we got back. So as far as kind of getting over some of the technical hurdles and making sure that not only can we engage older adults, but really the task here is like to delight older adults, because you need to retain folks over a long period of time for any of these solutions to have a real impact. So that bar gets risen pretty high. For us, it was a step-by-step approach, and I'd encourage entrepreneurs to take a similar one. When you are initially building out your technology stack, test it in a small environment, show the world your results. So we did a small feasibility study with only 19 patients out of New York Presbyterian, Weill Cornell, and took folks with advanced disease, with low tech literacy, and gave them the devices and the app, and saw really good engagement. Also learned a lot about where we could do even better. So thinking about the design around the unique needs of a senior, people with mobility or eyesight limitations is important. I heard you talk before about just access. So one, you have to solve for people who have access. How do you make that engaging? But the second is, what if you don't have access and there's a limitation to broadband access, device access, things like that? And the way that we approach it, and I think many others do, is don't be so married to the vehicle of delivery of care, be married to delivering that care. So if you have a member in a population that needs to talk to you on the phone because they can't use the app, don't discard that member. Go find a way to deliver value to them, and over time, potentially bring them along and help them with social support to get access to a device if they really need it, or help talk to them about how they can set up their Wi-Fi router. I mean, we do these things every day. It's about, overused words here, but really truly meeting people where they are and understanding how important that is, especially with these populations.
This has been fantastic, and Geoff, I recall in one of our conversations that MA being this lifeline and lifeblood for innovators who are developing these innovative solutions for chronic conditions, COPD, diabetes, cardiovascular health, and essentially are supporting them for the commercial success. In last 1 or 2 minutes, Geoff, what message do you want to share with our audience member and executives who are listening today?
It's a great question. I'm tough to limit it to 2 minutes, but I will. And I'm going to try to also answer that question from before from my perspective too in this ask. And it's kind of rethink, use Medicare Advantage, I think is a perfect place for it, to rethink some of the incentive structures and the models around how is care getting paid for, what are the incentives for different behaviors. I mean, if you look at the study that just came out of JAMA, where Humana looked at fee-for-service Medicare versus Medicare Advantage results across 1.8 million frail, major, and minor complex members, you saw lower hospital stays, lower readmissions, and lower ED visits, where you broke the fee-for-service rails and moved to two-sided risk. So I think, first of all, for all innovation, like that is the key. We have to really commit to this move to value. Medicare Advantage is the place that it's being done. Now, I would ask every Medicare Advantage plan leader, policy leaders, and others to bring us your hard problems and tell us what success means. So I want to know not only that you have members with COPD who could use care, but yet you're trying to achieve these following results for those members living with COPD, and you're looking for a partner to help align to the upside of achieving those, to align to the downside of not, and roll up our sleeves and build together. Beyond that, the whole field needs more opportunities for innovation, continuing to provide access to pilot and evaluation programs, really thinking through what the next few years can look like as these things come to scale. And again, continuing to, I love crossing that 50% Medicare Advantage enrollment line in the next year. I can't wait to see it go to 75 and hopefully serve as many of those members as possible.
Fantastic. We are coming to an end of our innovation stories today, and please, can we have a round of applause for Geoff coming in today,
And you, Smit.
all of us for trying this new model on the hybrid world. And again, thank you for listening in and wishing you a wonderful rest of the summit today.